Hello, I'm Dr. Sanket Mehta, GI and liver surgical oncologist from SSO Cancer Center. When someone hears that colorectal cancer has spread to the liver, that it's now stage 4, the first thought is usually, does it mean that it's still curable anymore? But here is something most people don't know. Even in stage 4 colorectal cancer, if the spread is limited to the liver, we may still be able to treat it with surgery, and in some cases, even aim at a cure. In this video, I'll explain how we decide whether liver metastasis can be removed surgically, what we look for, and why stage 4 doesn't always mean that people need to fear it. Let us start with a simple idea. When we say that a liver tumor is resectable, we mean that it can be safely removed through surgery, and after removal, the remaining liver will still work well enough to support life. That's the goal. Take out the cancer completely while leaving behind enough healthy liver tissue. Now, this decision isn't only about how many tumors there are. It's not only about the size either. It's really about where they are located in the liver, whether they are close to the blood vessels, and whether we can still preserve enough functional liver tissue after surgery. That's what we call as the future liver remnant, or FLR. If we can do all this safely, then yes, surgery is possible. Here are the main things we consider. First, the number of the tumors. Now, this surprises people, but even if you have 4, 5, 10 or even more tumors, that does not automatically mean that it's inoperable. If the tumor are in the positions we can access easily and remove safely, surgery can still be done. Second, we look at the size of the tumor. Again, size matters, but it's not the only point. A large tumor can sometimes be removed just as safely as a small one, depending on where it is located. Third is, of course, the location. Are the tumors near the portal vein, the hepatic veins, or the bile ducts? If so, we may need more advanced techniques, but that does not necessarily rule out a surgery. We also check how the tumors are distributed. If they are spread across both sides of the liver, we might be able to do a stage surgery or consider pre-surgical strategies like portal vein embolization. And finally, we assess how much healthy liver will be left behind. That's the FLR I mentioned earlier. If the remaining tissue is still too small, it won't work properly, and in that case, we look at a strategy to grow the liver before the surgery. Now, we don't label tumors just as operable and inoperable. It's not black and white. We think of resectability as a spectrum with 4 broad categories. One is clearly resectable, where we go in straight for the surgery. Second is borderline resectable. Surgery is possible, but we may need to plan carefully or do it in stages. Third is potentially resectable. Not ready for surgery right now, but if the tumor responds to systemic therapy, surgery might become possible. And fourth is unresectable for now, meaning surgery wouldn't be safe or helpful in the current situation. But here is the most important point. Just because something isn't resectable today doesn't mean it won't be resectable later. We often reassess after a few months of treatment. In fact, many patients who weren't candidates for surgery at first become eligible after chemotherapy. Can systemic therapy make surgery possible? The answer is yes, and this is something we do very often. We call this conversion therapy. The goal is to use chemotherapy, target therapy, or immunotherapy, or a combination of these to shrink the liver tumors, reduce the number, reduce the size, and make surgery possible later. We repeat imaging every few cycles. We track the tumor markers like CEA. And if the tumor shrinks, or even if it stops growing, we revisit the surgical plan. We are not always looking for perfect shrinkage. Even a partial response can sometimes open the door to surgery. That's why these patients should always be reassessed by a liver-focused surgical team, not just once, but throughout their treatment. Today's liver surgery is far more advanced than what it used to be. Let me give you a few examples of techniques we use. Parenchyma sparing surgery. Here, we remove tumors while leaving behind as much healthy liver tissue as possible. Two-stage hepatectomy. If the liver tumors are on both sides of the liver, we address one side of the liver first and then do the other side as a second surgery. Portal vein embolization. We block part of the blood flow to the side of the liver that is affected more so that the other side can grow for a later surgery. And R1 vascular resection, where tumors that are touching major blood vessels are carefully peeled off using natural planes without damaging the blood vessels. All of these approaches are designed to increase the number of patients who can benefit from surgery even in complex cases. High quality imaging is at the heart of this planning. We typically use a contrast-enhanced CT scan with liver protocol, an MRI, especially to look for smaller or borderline lesions, sometimes a PET scan to ensure that this tumor has not spread anywhere else, and a volumetric analysis which tells us how much liver will be left behind after surgery. But beyond this, we now have access to AI-based surgical planning tools. We feed the CT scan into the specialized software like Synapse 3D or Miriam, which generates a 3D cast of the liver. Using AI, it allows us to simulate resections, map the exact lines of surgery, calculate the precise volume of liver to be removed and what will be left behind. This means that we can plan our approach down to the smallest detail, even before the surgery is actually done. There are a few situations where we may not recommend liver surgery. If the cancer has widely spread to other organs like the lungs or the peritoneum, if the remaining liver after surgery would be too small to function, if the cancer is growing aggressively despite systemic therapy, or if the patient's general health won't tolerate a major operation, these are the situations where we would not consider a surgery. But even then, it does not mean we give up. Systemic therapy, targeted therapy, and close follow-up still plays a vital role. And in some of these cases, patients may become surgical candidates later. In some situations where surgery isn't feasible, we can use other techniques like radiofrequency ablation, microwave ablation, or stereotactic radiotherapy in selected cases. These methods destroy small tumors even without removing them, using radiofrequency energy, microwave energy, or radiation. They are not a replacement for surgery, but they are very useful in specific cases, especially for small or deep-seated lesions. Now you may be wondering, if I go through the liver surgery, what are the chances it will actually work? For patients with liver-limited colorectal cancer who undergo a complete surgical resection, the 5-year survival rate may be over 40 or 45%. And yes, in some carefully selected patients, long-term remission and even cure is possible. That's why we take time to make these decisions so carefully, because the right patient, surgery can be life-changing. Let me quickly clear up a few myths we hear very often. I have too many tumors, so I can't get surgery. Not true. Number alone does not decide it. It's touching a blood vessel, so it's inoperable. Not always. We use advanced techniques to operate safely even for lesions near the vessels. Chemo didn't shrink the tumor all the way, so surgery won't help. Even partial response may be enough. My doctor said it's not resectable. Get a second opinion, especially from a liver-focused team. That assessment can change. And finally, stage 4 means surgery is off the table. That's simply not true. In colorectal cancer with liver-only or liver-dominant spread, we can always approach the disease. Let's end with this. Stage 4 is not the end of the story. When colorectal cancer spreads to the liver, it's serious, yes, but that doesn't mean it's untreatable. If we can remove all visible tumors safely and preserve liver function, surgery can offer long-term survival and sometimes even cure. But resectability isn't something we judge once and forget. It's something we keep reassessing with every scan, every chemo cycle, and every clinical review. If you or someone you care about is facing liver metastasis from colorectal cancer, ask the right questions. Is this potentially resectable? Can we reassess after chemotherapy? Should we speak to a liver surgical team? If this video helped you understand how we make these decisions, please like, share, and subscribe to stay informed, because in cancer care, information is power. Thank you for watching.